I'm just going to ask a couple of the first questions and then we'll go out. And one of the themes that I heard in, oops, push to talk. Speak. It did say that. We're going to ask just a couple of questions that I'm going to ask, and then we'll go out to the audience. And one of the things that I heard almost everybody talking about was the sense of power and powerlessness in the relationship, in people's relationships to their health and to their healthcare providers. And I'm really interested in what makes people or can make people feel more powerful and what makes them feel powerless. And I'd love to hear you talk with each other a little bit more about that. Rebecca.
I just wanted to say one thing in terms of, again, disenfranchised populations, because I think this is sort of important. When we've talked to some of our patients, initially 66% of them said, why would I talk to my doctor? They don't help, like, why? Like, they didn't even know that that person would be someone that could help them. And I think, there are those people who see their doctor often, but in a lot of places where there's limited access, rural populations, urban groups, they don't see their doctor as someone that they have a close relationship with. And so I think that we have to sort of think about things that we can do for lower hanging fruit for people who do have that wonderful relationship, and also think about how do we empower people who maybe seeing a new resident because that's the only person that can see them, or they only get into the hospital or to see their doctor every 6 months. I think we need maybe different types of things for different groups.
Joy.
Can I build on what you just said? Because I think it's really important. It's something that I really didn't bring out in what I was speaking to. Having that close proximity, it's critical. And that's why a lot of when we're thinking about, how do we move out into the community, we need to be tapping into the people that they talk to. One of the things that comes out, if Aunt Bessie says it ain't so, it ain't so. And if you're sitting in the doctor's office and they say something, they'll be real nice and they'll be polite. But if Aunt Bessie says it ain't so, it ain't so. And if that's not what happened to Uncle Ralph, they're not believing you. So it's really important then to go out into the community and understand what their beliefs are. That I think that's critically important. Secondly, I think that a major issue, and I do teach communication in the School of Medicine, and one of the reasons, and I have
my condolences.
No, actually, it's pretty good. I whip them into shape pretty good. I'm old, but they also work on the qualitative studies that I do, and I have them do assessments of what's going on in the clinical setting, and then I have them reading the transcripts of what people are really saying is going on. Two different worlds, and it's very sensitizing to them. But finally, I think the critical component is if we talk about empowerment and getting people empowered to talk to their physicians, these are people who are disenfranchised, who have been time and time again been pushed out, put down, and they go and they're not heard and they're not listened or they're poo-pooed, then we've done harm. So that's I really focus in on the side to make sure that the healthcare professionals are worthy of what they have to say.
But Peter says that patients want their doctors to like them. Peter, how do you respond to?
But I think all that's true, and certainly I grew up in a rural area with a lot of people that weren't wealthy, and but the reality is, so it's sort of a continuum. Because, even the wealthiest person is sitting there in something with his butt sticking out, it doesn't even cover your behind, the thing that you're wearing. And it's sort of, to me, such a good symbol of how a patient feels. And there's people that feel in many ways interacting with institutions that feel the institutions aren't hearing them. So it's only, doubled down as worse. So, but they would, if they're open, they want that connection. They want it to work. They want to get the solution. They're in a really weird place. It's like when you do focus groups in a focus group facility, it's like the worst possible place to get honest answers in the entire earth. Yet we still do it. But they're in a different environment. So I think the idea is the powerlessness of the doctor-patient relationship is You're on their turf. They're the people that have all the information, and the information you have, which is everything about yourself, that expertise is not honored. And that's a huge amount of expertise. You are the only person that's an expert on you. And that's in fact part of the way we found is the most, through our endless research, the way we found is that, something that people of all income levels could kind of gravitate to. Yeah, that's definitely true.
I'm curious too, because you talked a lot about the issue of control too, and I'm curious, do you find, and Rebecca, you might answer this too, do you find that having any conversations when you're not sick is significantly different than when you are sick? Because when you're sick, you probably feel a lot less powerful anyway, and is that a cohort that can make change in the system, the people who are the not yet sick?
I think it kind of goes back, and I think, Nick, you brought up this word, which is normalizing. For those who have done sex education, I think we have, before you would never ask somebody a question about, sex and things like that, and now it's sort of a normal part of what you do in the office. And I think if we think about starting this upstream and getting it out in the community like you're doing, and it becomes just sort of what we do, it's expected that it's going to come up when you go to the hospital, when you go to the emergency room, when you see your doctor, when you see the physical therapist, when you talk to the pharmacist, when somebody from Meals on Wheels comes to your house, whatever it is, that it's part of the conversation. I think that's one of the things I always say, and this is so true, and I think anyone who does palliative care consults in the ICU, those situations where you walk in, somebody could even have an advanced directive, but nobody's been talking about it over a continuum, and they're still like a deer in headlights. Or the other family who can say, like, yeah, we don't have an advanced directive, but we have been talking about this for 20 years. It changes the complete dynamic, because there's something, normalized about it, and people, I think the other thing is that if people are having these conversations over time, people can see how they're changing their values and preferences over time. And I think when we have, I guess, in the medical environment, this one and done, like we got the advanced directive 10 years ago, so we're done, I think the message has to be, this is normal, and just like your insurance policy, we got to renew it like every year in terms of where you are.
So I want to
Go ahead, Nick. I'm sorry, Peter.
Go ahead, Nick.
Nick.
So I just wanted to jump in there, because I think when we talk about conversations, we often think about conversations between two people. And I think when I'm lucky enough to get to observe a lot of these conversations. And one of the things that happens when you insert a tool that makes people take turns is that people without any power in the room start to speak. And this is one of the rules in the game, is that you have to listen when other people are speaking, which is a powerful thing, especially when you have a physician playing the game and they have to shut up. And if they don't, there's somebody with a set of instructions that says, no. Says on the instructions that you have to be quiet while I talk. But then there's this whole circle of people, and I looking at Conversation Project videos over the years, that's one of the things that I've noticed, is that often when people are talking about these conversations, it's the people who you wouldn't expect, and the people who don't have a lot of power, the grandchildren, the people who are a little bit separated off, who get a turn to speak and then can model that for other people. And I think that's really important, that we don't set up just a dynamic, that it's not just two people, that there's a whole group of people, and that they all get to model for each other. And I just think that's a really important thing when you talk about power, that it's not just two people looking at power, it's how power gets distributed and changes and moves over time, which I think is really important.
Why don't we open up to questions, and Judy?
Hi, thank you. First, I'd like to say I'm Judy Paris with Social Work, Hospice, and Palliative Care Network. I'd like to first thank Joy for reminding us that we've all been here before. Some of us have been here before longer than others. And so it's a nice reminder that the Patient Self-Determination Act was passed 26 years ago. And the second thing is thank the panel for all the good work that you're doing and all the tools that you're bringing to the public. And I constantly have been mulling over the idea of dissemination. I also have a clinical practice. I sit with Medicare beneficiaries, like many of you sit with terminal illness and serious illness. And they don't know any of this. It's not anything that their physicians know. That I know of all your tools and that I can help tell them where to go is something. But I'm astounded at how much the dissemination is not out there. So I'd be interested in the panel's thoughts about dissemination. Also, Ellen mentioned with the Facebook ad that you had such a great percentage increase. So I'm just wondering what you all are thinking about dissemination.
I can try that as the person that pays for all these campaigns or guides a lot of these campaigns. So dissemination is really hard because, guess what? We're not the only people competing for people's attention. We're not the only people buying Facebook ads. So it can get very expensive to when you have a theory that we're going to be got milk. Got milk, because I always use that as an example. That's $110 million a year, okay? So when you have the 110, and by the way, give me a call when you have the $110 million a year campaign. But most campaigns can't do that, so I have to think about the dissemination has to be thought about in the way you do it. It can be through having the hospital staffs. Now you've shrunk the population. Play the game, for example, to learn. That's a great sort of doable dissemination. To have, we want to make the product, both the Dr. Dakota and the Trust Card, something that primary physicians will want to incorporate into their practice, because there can be a helpful plug-in from their end of learning things about patients too. So that's another, not a sustainable model is to be, Pepsi and Coke, unless you have a profit margin like that. Then you can keep doing that in. So I think it's about thinking about how these tools are useful to audiences that already have eyeballs themselves. So in other words, we have to get into systems that are already having people flow through them in order to get that, instead of a dissemination model of screaming on top of the mountain, because it's really expensive to scream on top of the mountain, as it turns out.
Well, I was going to ask Ellen if you could actually address this point, because I also know that you've worked a lot with the media, script writers, things like that. I don't know if you want to talk about that experience.
Well, we've had a couple of meetings with the writers group on the East Coast and on the West Coast. And maybe some of those meetings with screenwriters got into the plots. It's really hard to trace that. You can't trace that directly. We also have had a lot of media work, and we have our PSA campaign, which went up briefly all over Boston. I mean, I think it was 6 weeks, Harriet, was it? 6 weeks, all over the Boston subway system, and then in the pop-up ads. But it's hard to get funding for media stuff. We have an entire treasure box of our fantasy videos and animated stories that we want to create to go viral, But again, and those aren't the $100 million a year Got Milk campaign, because social media may be at least as effective as this sort of ad council approach, the scattershot to that. But again, these are hard things to get funded, and so we're doing them one at a time. And I think the idea of wholesaling, going through various organizations, can be a very useful one. But it's also true that you need to go directly. I mean, that's why we've been collecting and sharing. We have a project of a storyteller project that we're devising a strategy for collecting and sharing stories, because those stories are very powerful. People want to share them with each other, but they also tell the public that this is normal. I mean, our model for social change has always been something akin to the birth and how birth changed in America. That birth didn't change in America is because doctors said, you know, please come in, bring your video camera. Dads, come on in, let's have the baby in a bathtub, you know. It didn't happen that way. It happened because people said, you know, giving birth is not just a medical experience, it's a human experience, and we want it to be humanized. So there's this relationship, the double helix thing. This is relationship between change that is in the institutions and a supportive environment outside of it. I remind you of death panels. When we started the Conversation Project, it was right smack in the middle of death panels. And you go by 5, just so that you don't get totally depressed, Judy, about how long these things take, just 5 or 6 years after death panels, we got payments for having these conversations, and the culture has changed. So much as we're frustrated by the fact 90% of Americans want to have the conversation, 30% or maybe a little bit more have had it. You know, much as we want to close that, just to remember that this is really a powerful social change that is occurring right before our eyes. And one of the reasons it's occurring is because of the baby boom generation, who have been the change agents of our whole culture. The civil rights movement, the women's rights movement, the gay rights movement, and they are now dealing with their elderly parents dying and with their own friends and themselves getting sick, and they are not going to go gently into that bad good night. They are going to want to do it differently. So I think this is a prime moment, and I think we are at the proverbial tipping point, but it's going to require quite a bit of energy not to slip backwards, because, you know, why is this such a hard subject? You know anybody who's really eager to die? You know, it's just tough stuff, and it's about loss and grief and mortality. So that would be, but to do this in the culture at large is essential as well, because, by the way, doctors are part of the culture at large, and they feel that sea change as well, and they respond to patients as much as patients respond to doctors.
One way to think about it is we need our death panel. You know, death panel was stupid, crazy, wrong. You know, I can go on, obviously. But it was viral, and it was big, and it was not, you know, had some money behind it, actually, but it was not got milk. So there was some evil genius there, and take the evil out, and we, you know, add the genius. So you can think about that. It is. I mean, catching the imagination of the public by connecting with something. That, you know, it's about that connecting. It's not about persuasiveness. It's about connecting with them.
And we're connecting with it because everybody has a story. Just with my journalism hat back on my head briefly, I've never seen anything like this in terms of, like, you tell people what you're doing, and this half a beat, and out comes a story. And this has happened to us. We've had this experience over and over again, including with journalists who are doing stories about us, and we're having this conversation, and they all have a story. You know? So that's the power of the work that we're all doing. Do we have over there? Yeah.
Hi, Joanne Lynn from Altarum Institute Center for Elder Care and Advanced Illness. I'm trying to gently give voice to some qualms. I very much believe in advanced care planning. In all of my clinical work, I've run more than 90% rates. 25 years ago, we started a randomized controlled trial, which has not been repeated since, which showed that excellent counseling and very good planning made not a single jot of difference in anything measurable. No one has actually improved on that. I'm willing to believe that the world has changed in whole lots of ways. I'm actually willing to believe that the obstetrics changed not just because of our bodies ourselves and women demanding difference, but because the habit patterns changed. So that someone showing up who said absolutely nothing got a much better deal in childbirth. We changed the habit pattern, the workflow. Have we changed the workflow in important enough ways to believe that, as Rebecca kind of threw off in a side comment, that advanced care planning really makes a difference? I've come to believe that in this world at this time, yes, advanced care planning needs to be done, but it is a very small part of comprehensive care planning. Our image when we really launched advanced care planning was mostly that of turning things down that were readily available. You turned down the ventilator, you turned down the dialysis, you said you wanted to go home rather than to be in the hospital. Now, in most of the practice that I'm familiar with, the problem is that the things aren't there. The wait list for Meals on Wheels is more than 6 months in most of your cities. The housing is just not available to disabled people.
So that's a good question. I mean, Americans do face two conflicting fears: the fear that they won't get the care that they need, and the fear that they will get care they don't want. So
let me just
Rebecca,
finish
do you
one
want to
piece,
respond to
which is
that?
that I think that if we think of comprehensive care planning as a mutual endeavor that requires co-production, that requires that you know a lot about the person's living situation and what the community and their insurance and so forth can actually provide, and you're coming up with the best possible plan, then the enablement of the patient and family are really fairly automatic. And advanced care planning around what you're going to turn down and the end of life becomes an automatic sub-piece, but you also are dealing with how you're going to pay for this and who's going to leave their job to take care of mother.
Thank you.
So, yeah, I mean, first of all, I can't agree more with you that advanced care planning is a small piece of a much larger whole. And I'm going to channel Diane Meyer, who basically says advanced care planning is great, but if you don't train a workforce to actually be able to provide the care that people are saying that they want, then what are you doing? So I think that it's important to see that it's a piece of a larger puzzle. You need the workforce, you need Vital Talk to train people to have these conversations. You need to train palliative care physicians that can give the care that they need. And I think one of the things too, in terms of the work that I'm doing, and I know other people are doing, is thinking about advanced care planning, not just about medical planning, but about life planning, which includes the involvement of medical legal partnerships, helping people stay in their homes, thinking about what to do to take care of their children, those kinds of things. And I think as the second panel this morning was talking about, we do kind of need to get out of our silos and think about how we can sort of work across our community, I think, if we're going to make larger impact. So thanks for the comment.
I think we should go back to that question as the last one. How do we all get out of our silos? So hold that thought for a moment. Of Blood, you want to?
I just want to make an observation, which is that I was very taken, Peter, by what you were saying around language, which of course is the ticket to everything, the language that we use, because at the end of the day, we need to bring people in. And I am guilty because I've been talking about Courageous Parents Network as a tool that empowers parents, but parents don't feel disempowered. Like you've reminded me of this, and I'm like, oh my God, what have I been doing? And so I just think power, we've been using that word a lot, but that's a very inside term. People in it only realize that they don't feel empowered or that they feel disempowered in a crisis moment, which is not the time that you introduce an intervention like that anyway. So like, I'm just struck by the words that we need to use that get people earlier. And if you don't know you have a problem until you're in your problem, what is the language that we use? I'm just acknowledging the trickiness of that. And I thank you for making that observation for all of us.
And I'll give you the $5 in just a while. But for, no, one of the things I wanted to say, and you kind of hit on it earlier, was part of it is the normalization, but it's also like building muscles over time. And that was why we moved back earlier in the continuum from where we kept going to the wrong place enough times that we finally learned to move back in the continuum and have people develop relationships, build muscles, and it's sometimes you can think of it as it's the big system, it's the big plan, but it's also the little pieces. It's a lot of little pieces that add up together. Someone said little habits over here. I think that's the kind of thing. And that's the idea of the doctor to code is having the question come up to a similar question come up to a doctor again and again changes the thinking. Having a card that one of the things the card says on it is, I can handle the truth, and one of the questions is, would you like the straight truth or would you like us to sugarcoat it? And there'll be maybe a 10% will say, no, I'd like, please sugarcoat it. But most people say, I want the straight truth. I think that gives doctors permission. You talk about everybody in this equation, the family, the doctor, the patient, all of them are looking for permission to do different things from each other, and it's not happening. And the family showing love in a way that ends up just being bad for the patient sometimes, and the patient is trying to show love by not letting their feelings go, and the doctor's trying to show love and show care by not giving as much information as they could. So, it's that dynamic, and it's the small pieces of that dynamic that are huge. So whoever said small habits.
Yes.
Yeah, so I'd like to I really appreciate the innovation that you're bringing. And I'd like to just, and also that we're looking at comprehensive care planning. People do want to take control of their life and make that the entire parts of their life reflect them. And so thank you for that. The question I would ask is, are you really doing system thinking and being realistic about what resources we have? For example, we had marvelous examples this morning, moving, touching examples that people had long-term stable relationships with compellingly committed primary care physicians. Going out there in the real world, I see whole communities, they can't even get in to see their doctor, let alone have an annual conversation. So I would ask you, let's make sure as you build your tools, it's going to have to be a bigger team. It's not going to be a dyad. It's not even, I'm realizing as we're trying to develop systems of care, it's not even going to be a system of providers. How big a team can we get? How can we bring that patient onto the same team? And I think you're doing make great steps towards it, but I don't think we'll get to an answer until we think in that huge system-based approach.
Of course, that's some of the reason why people have to have these conversations with their family members at the kitchen table. They get the context then, and when there is a crisis, that family member who's the decision maker has a strong narrative basis for understanding the values and how to bring those to bear on the situation. I mean, obviously not universally, and we do need to connect with the healthcare system, but I think that is one of the reasons why a lot of this work has to be done. I mean, I think Nick could probably speak to that too, but a lot of this work really is people talking to each other, family members, people who love, and of course, as we all know, there are a lot of people who don't even have somebody in their life like that. But there are a lot of people who do and who can choose the person to make decisions for them if they can't make them for themselves. So, but Nick, did you want to add? Or should we?
No, let's take it.
Okay, another who we have.
Hi, I'm Pat Bomba, and I'm a medical director at Excelis Blue Cross Blue Shield, and I lead New York SMOLS program. And so I really thank the panel for all of the innovations, but also wondered if we might, or if anyone wants to comment on communications around medical orders. And the two, from a population health perspective, we're really focusing on everyone 18 and older, and there is importance for culture change, as you said, Joy. But for the smaller group of folks who are appropriate for medical orders, to ensure that they get what they want in an emergency, we need to translate those into medical orders. People who might die in the next year, people in nursing homes. And having led New York SMOLS for over a decade, there is a lot of work, as Jim just said. It's culture change, public education, clinician training, but it is workflow and policies and procedures and a big system change. And I think, Rebecca, you said about accessibility. Once these are done, can they be accessible in an emergency, either in an EMR or for EMS in the patient's home? And so I don't know if any of you have been involved in that, but from a public education perspective, what we've seen in New York is people don't get the difference between advanced directives and medical orders and the different populations for whom it's serving. So I'd ask if anyone's working on that from a communications perspective, what your experience is.
Joy, is that something in your world?
It's something in my world. It's not something I do. Dr. Woody Moss from West Virginia has been a champion of this, and we've actually had quite a bit of success in West Virginia for those people that this is appropriate for and this is what they want. He's had a lot of success, but it takes a long time. You know, you're shifting the culture, getting the word out, and he's done a very good job of that. But that's about what I can say. But it is a model. I would contact him.
Oh, I run
You know
New York's program, so I know it and I know
Oh,
Woody.
okay,
What
you
I'm
know Woody.
saying is that
Yeah.
there is an important part for public education to ensure that people understand and do early conversations, choose a healthcare agent, everyone 18 and older, but also to make sure that people for whom the National Pulse Paradigm Program, whether it's in West Virginia, New York, California, or anywhere else, that cohort of individuals understands what that means.
Right.
Right.
Because the whole conversation is different, it's not about future care, it's about right here and right now, understanding health status and prognosis. It goes back to some of what was talked about in earlier sessions.
Right.
Thank you. Amy, do you want to?
Sure, thank you. Fantastic panel, and I agree, great innovation being discussed. And let me just say that I have used the conversation starter kit. I have played a Final Friday with Hello, and I've done Prepare to Care, by the way. I've used all of the tools, and they're fantastic. So I'm going to go a little rogue and ask a different question. Healthcare is also something that we purchase. It is, in fact, one of the biggest purchases that individuals make in the course of their life. You know, they pay for their medical bills. It's a big expense. And as we think about the power issue, my question to all of you is whether or not today you feel that we truly are empowered. And I'm going to give a little context to this one. Ellen, you wrote a story in 1978 in the Boston Globe.
I was in grammar school.
Front page of the Boston Globe about a comatose elderly woman in her final stages of Alzheimer's who was unable to do anything on her own, contractured, bedbound. And the family requested that she be able to refuse care, and there was no advance directive. Out of that court decision, which was the first time that said you don't have to go to the courts, that we can in fact have physicians acknowledge the wishes of the person or the family through an advance directive, it was the language that said about the Patient Self-Determination Act. And I, of course, know, because we're connected, that was my grandmother. And you wrote that story. All these years later, and I appreciate you so dearly, and I appreciate your continued deep interest in this space, even before your sister, your deep commitment to this space. Today, still, if we are to complete an advance directive, if we are to empower ourselves, the question is whether or not we know that that document will be respected. So I just need to raise the issue. How empowered are we? And I'd love to get your thoughts on that.
Nick?
So clearly we're not empowered now. I mean, I think all of us probably have examples we can point to where, you know, I spend some time observing in an ICU and you know, with nurses and doctors who are fantastic people and who are terrified and who are tired and who are all the things that make it not possible for them to really do all the things that they need to do to be empowered or to do the things that make their patients and families empowered. I think in more cases than we believe, we're close. The thing that strikes me most about all of the teams that we get, I talked about one of the teams that we worked with, but there are these moments with those teams where they start realizing that not only do they get to not have families scream at them for providing bad care and not have letters get written to them about what awful care they provided, but they actually like feel that thing where they are providing the kind of care that they went into healthcare for. And that happened, I mean, it's just like, it's a magical, magical moment. And I think at that point, you get teams that are working together, that trust each other, and therefore know how to learn how to, trust the patients and trust the families. And at that moment, you start to have people actually be empowered and actually make decisions for themselves and have other people get out of their way, leave some of the power that comes with being a doctor or nurse and put it back into the power of the patients and the families. So, does that work every single time? No, but it works a lot more often than you'd like to believe, I think. I mean, I've seen it happen a bunch of times, and it's always a little bit surprising, but I'm starting to see a pattern. But that requires that everybody take time to get to know each other. It requires teamwork. It requires acknowledging that we are human and frail, all of us. And until we get to that point where healthcare teams acknowledge their frailties, there's no chance of that. But when we do, it actually happens. And I think there is no more powerful thing for change than for somebody to believe that they're doing the job that they got into healthcare for. I mean, it's just like, it's a magical moment to watch a nurse provide care that she knows a patient really wants. It's just beautiful. And that beauty is the thing, I think, that will create change.
I think I would add on to what Nick was talking about, because the work that we're doing is about bringing the person into the room and is person-centered. But it is also about restoring trust and joy to people who are in the healthcare profession. I mean, it's absolutely, if you feel pressured, if you feel like you have to keep either providing or denying care to someone, if the clinician doesn't feel like they have some measure of benign power over the work that they do, it's lousy. It's a lousy way to live, and it's not why they got into it. And that's why in general, they got into it because they wanted to care for people. And that is a lot of what we're talking about restoring. At the same time, I am very aware from many personal experiences and observations that the most important thing that you can have is an advocate in the room with you. Don't go to the hospital without someone who loves you, who knows what matters to you. That person is the one who will protect you from bad things happening. And so that would be, both of those things are true. And a lot of times bad things happen not because doctors are wanting them to, but because they are out there on a diving board a lot of times. So do we have time for one more question? Okay, one more question.
Jeff Cohn, I get to work with Nick at Common Practice, and just more a comment than a question, but interested in people's thoughts. A lot of people talking about power and empowerment, and I'm of the belief that actually what we need is less constraints than more power, that the reason why so many of us feel as though we're not empowered is because we're going up against brick wall or something that's imposed by the healthcare system. And so if we create the space for the conversations and make it clearer that we really need them in order for us to do our jobs well, then that those muscles that haven't had the chance to be used within patients and families get to show how strong they really are. So, we've heard a number of people talk about ask, tell, ask. And if I could do anything, it would maybe be to add a few more asks in the beginning or end of that, just to reflect how important it is for us to learn stuff from the people that we're caring for that we don't know in order for us to do a good job.
By the
Well,
way,
thank you. I
as-
think that's a wonderful way for us to end the day. Ask, talk, ask day. And thank you all for staying with us for such a long day. It was wonderful.